Hello, everybody. Welcome to our September 16th Gravity Project public call. We do, as always, have a fairly action-packed agenda. So even though it's just the top of the hour, I am going to start in and folks should join over time. Again, my name is Sarah DeSilvia. I'm the Director of Informatics here at the Gravity Project, and welcome to the call. Next slide, please. We always do try to refresh on the kind of like meeting communication strategy. So we always mute everyone upon entry just because of the usual number of attendees. We usually get up to at least 120 folks or so per call. We ask that you remain muted to avoid background noise or feedback. The calls are always recorded so you can find them after the fact. We do encourage and heavily reference the chat feature. So if you send a chat to everybody, we'll integrate those comments into the conversation as appropriate. We do ask that any conversations in the chat try to reference what's happening in the public call in order to just make sure that our focus is on what needs to be addressed. If there's a specific side topic that's relevant, we can try to integrate that into future meetings, or we can kind of pause or ask that within our question breaks. When you are chatting, just please send them into everybody. And I do just note that if anything's sent to me personally, I will likely read it out loud because I don't have time to discern everyone comments from personal comments. That's just a warning. All right, next slide, please. This is our standard antitrust practices slide. This is just part of our legal matter that we have to mention every meeting. Next slide, please. This is really just general information regarding joining the Gravity Project. So if you've not already joined the Gravity Project, please do so. You can check on your status as well at the links. As we talk, the links on the presentation should join. You can see them popping up into the chat for easy reference. Just as a note, sometimes you have to click on them twice because of WebEx proxies, but you should get to it if you click on the link twice. The Confluence, of course, is always a bevy of information. Next slide, please. These are our founders, grantors, and in-kind supporters. Next slide, please. We are looking for sponsorship for 2020. If you want to learn more about sponsoring, you can write our standard email, gravityproject@emyadvisors.net. There's also information on sponsoring on the Confluence. Next slide, please. I'm going to go through some announcements and then go through the terminology work. Mark will then have a policy update. Bob will have a tech update, and then we'll close with community homework and next steps as usual. Next slide, please. Next slide. Oh, look how busy this is. I'm going to need help. This got considerably bigger since I made the slide, so I'm going to ask for some help. I believe my colleagues are on the call. So we always just do want to announce the HL7 Fire Implementation Guide public meetings. It's kind of the sister to this meeting where we focus just on the Fire AG. Those currently happen from Wednesdays between 3 and 4. We do want to mention that there's a new ANSI information exchange for human services consensus body. So Evelyn, are you on the call, or Linnell, or someone wants to speak to that? Or one of our colleagues?
I'm here, but I know we have several. I think I see Brian as well. We just received this announcement, and there's a webinar, upcoming webinar. So it is focused on developing, building off the direct protocol. So for those not familiar with it and want to learn more, there's an upcoming webinar. And Brian, I see you on. Anything else you want to add? You may be on mute. Brian Hanspicker has been involved. Okay. Yep. No, there's lots going on. I think this is more of a snapshot for everyone. So Sarah, you don't have to spend
too much time here
through them. Yeah.
Okay. Yeah. So I do want to specifically call out. I mean, there's more information on each of these on the Confluence announcements page. I do want to specifically call out, because it's relevant, publication that we worked on with Healthify. They were the principal authors, but we assisted regarding the ICD-10 CM SDOH code expansion that is going live in October. So all of those new Gravity codes. And then we've already talked about the Sync Health Conference. And then, of course, all this information is available on the Confluence. And the link to the Healthify document is in the chat now. Next slide, please. Just always going to reference that the code in build is available on the Confluence. Some updates to be made with our new SNOMED code that came out just recently, and then of course going to update again with ICD-10 CM in October. Next slide, please. All right, next slide. No changes to this right now. We do have some updates on the Connectathon. Bob will give that during his technical presentation. No changes in the terminology section, so I'm going to try to keep on going for the sake of time. You can see that we're working on our interventions and goals work with the domains we covered this spring. Next slide, please. All right, any questions from what we just presented?
Sarah, I'm about to put a link to the IX4HS, that second bullet on your previous list, a link to that for anyone who would like to attend.
Wonderful. Thank you.
And I'm also, this is Brian Picker, I'm also willing to answer any questions or concerns that come up about it, since I was one of the folks, along with Lucy and some others, instrumental in standing this up. The intent of IX4HS is not to be in competition, but rather to create an opportunity for collaboration between the Gravity Project, HL7, Direct Trusts, IHE 360X, et cetera, from a human services perspective.
Wonderful. Looking forward to learning more as we go forward.
Think of this as like the Karen or the Da Vinci efforts, but focusing on profiles for how we make use of existing standards to meet the needs of community-based providers of human services.
Yes, I'm looking forward to more information regarding that in our technical committee that we share as well. And there's, as far as that, there's no link to the Healthify resource that I have found that doesn't require putting in some information. I mean, I guess we can try to get that otherwise, but it is a Healthify licensed piece. All right. Okay, next slide, please. Okay, any other questions? All right. It does reference Gravity a fair bit, but again, we didn't write it. We just assisted. Okay, next slide. All right, so we just want to give some updates on the 2022 ICD-10 submission. So I'm going to really try and be clear. So I'm dating now our ICD-10 work by the year that it would come out. Okay, so not by the year that we've been talking about it. So the code to come in October is 2021, and the code that was just discussed at the September meeting is now going to be called 2022. So the topic packet you can find there. It was presented just yesterday. We do have some updates. So we did mention that we go out and ask our colleagues some information. So far with our VA and DoD colleagues, there's consensus behind going back to our submission as presented, which separates military service and deployment. And that was just, what we suspected would be the case. So NCHS, the committee, combined those two terms, and we are going to share a letter and commentary asking them to be split. Because it for many, many different reasons, and everything that we craft, of course, will be presented to the community for review. We also just want to say in general, we're in the process of developing a comment letter to submit regarding the proposal to support the proposal, as well as address some areas that were presented at the last Gravity meeting. The comments are due by November 15th for proposals being considered for October 1st, 2022 implementation. So expect that information, the comment letter, to come pretty short turnaround. And then as soon as we know information regarding how you can provide your comments to the Coordination and Maintenance Committee, we will let you know. And we really have these two kind of regular periods of communication. One is the public call, and then there are Tuesday emails. So that's a really good reason to be a member and be part of our emails, is these kinds of communications that might be timely, that might not want to wait for the next public call. So we're going to be giving information as soon as we can, both on the Confluence, in our public meetings, and in our email exchanges. Okay, any questions here? All right, next slide, please. Just wanted to briefly highlight some slides that we put together for a presentation on Friday. So Evelyn and I did back-to-back conferences on Friday with our colleagues at CIE, and then I presented to ACAP. Just wanted to briefly show how we envision accessing the new ICD-10 CM codes through two different pathways, one through standardized screening questions and one through patient story. We are developing education around these points, including the mapping to SNOMED very shortly, but this is how you might get to food insecurity. Next slide, please. So then we have our prepare and housing vital sign mapping, right? So the prepare questions and the housing vital sign mapping to housing instability unspecified. And then those specific questions that align with Healthy People 2030 and risk housing instability housed with history of homelessness in the past 12 months. And next slide, please. And then we did the same thing for homelessness. So you can see how you can get to general homelessness, sheltered homelessness, or unsheltered, whether it be through a screenings question and answer or through patient story. Really the point being that we, as we develop these deliverables, we have an intent to educate, but not just about how you can get there from our screening tools, but how you can just listen to patients and understand what the core criteria are. And get those. And this will align with work that's been done through the American Hospital Association and their coding clinics, et cetera. So again, this is part of assisting with the implementation of the code we develop. All right. Again, this is just for information. Again, very, very shortly, you can expect a more formal kind of desk reference, very brief detailing of how to get to the Gravity SDOH ICD-10 codes that's going to be current in October. A much more concise brief than the Healthify brief, which is quite extensive, right? We really want to make sure that it's as simple and intelligible, just for everyday use. All right, next slide, please. Okay, any questions on what we've presented so far? All right, now on to more terminology work. Next slide, please. All right, so here we are. We're getting close to our end-to-end review and voting for social connection, elder abuse demographics. Here we are on the 16th with still going over goals and intervention concepts. The demographics, goals and intervention concepts are proceeding quite swiftly. We have been working really hard to make sure that we get our goals and intervention concepts for elder abuse and social connection ready for you all. There's going to be a lot of information coming over the course of the next few meetings. So we do hope you're ready to attend so we can make sure that we're voting successfully on October 14th. Next slide, please. Lucy says, refreshing to hear about story instead of use case. Yeah, that's a Sarah term. It's like I listen to patient stories, and then that's primary care all day long. It's social work. It's care of humans. We just hear their stories and try to understand how to help define things so that we can take care of people. We just really, before we go into terminology work, this is really critical for this phase, where there's a lot of refining work to be done. So as we present the concepts kind of in the hopper and in process, We just really want to make sure that folks offer rationales for anything that they might feel differently about. And we do, for the sake of process, need these to be written just so we can appropriately log. So if anybody has any kind of specific concerns with anything that's presented, please present a rationale, because we can ensure you there are very clear rationales for everything that you're seeing. So much time with our intervention council and our subject matter experts to get where we are today. So if you have concerns, please just write us an email, and we'll try to make sure that they're integrated into our work. Next slide, please. And then we just want to stay, again, very similar to what I was saying before regarding the chat. So if you have questions about domains we've covered prior, we can take that offline via email, because we really are committed to having everybody catch up, and we've covered so much. Our roadmap is not large enough to cover everything we've covered in the past. So if something is relevant for a previous domain, we're just going to ask that we will notify that in the chat and then pull it onto an email so we can address your concerns. Okay, next slide, please. Any questions on the approach bit? All right, okay, next slide. All right, so this is us, the terminology team. Next slide. Here we are. There's a lot of what we call identifying. So identify is the word that we use when we are really in the process of discerning what needs to be said. And then we review what we've selected as needing to be said, and then we vote on it. So this is all happening in the next month. Next slide, please. Again, just gently saying all concepts are in process, and then we just need to figure out meaning, and we refine wording. There's a lot of like deeply philosophical conversations that happen in our meetings, as you know, and they happen in this meeting too. Like, how do we say what we mean to say? Really trying to make sure that all of our different stakeholder voices can understand what we have to say. So even though a concept might be defined, the exact wording might be in flux. Until we finally figure it out. And even in end-to-end review, I want to remind folks that also is a time for formal commentary. So really, it's really right up until the vote that we really are trying to massage these terms into what we exactly need to say in order to get the point across. Next slide, please. All right, so I'm going to go through social connection, goals, and intervention concepts. Next slide. Just generally going over goals and interventions. So we addressed all of these concepts with screening and diagnoses in the spring, and we're addressing goals and interventions now. So these are the things on our ticket before early December, when we take kind of a holiday break to do process work behind the scenes. Next slide, please. Really, when we talk about intervention development, it's about programs and professions, and we do try to align with federal policy and community taxonomies. And then all of these are integrated into the Gravity Project intervention structure, which is an evolution. Next slide, please. So you can see, as again, I'm presenting this as a refresher, because we actually are identifying possible missing terms within our structure, and I think you all will understand why. So right now we have assistance, coordination, counseling, education, evaluation of eligibility, assessment, which also includes a kind of evaluation. That we see evaluation of eligibility as a subtype of gross evaluation or general evaluation. Provision, which is to make available for use or to supply, and then refer. Next slide. And then you can see, really important, I think it's for everyone to know, there really are common interventions that we drop either the problem or its antithesis positive statement into across all of our different domains. So when you go to those master sheets, you should be able to see assessment for unemployment, assessment of barriers to education care plan, assessment of goals to achieve employment, right? So you take the problem, and then you take the goal statement or the positive statement, and you drop it into these different structure we have, and that's common across all of our domains. This is to represent care planning activities and counseling activities that really are critical for doing work across the healthcare and social care ecosystem. And this has been a structure we've had for, really, we developed it early, about now 2 years ago. It might need to be refined in time, but so far it's served really applicable for many of the activities of care that we do across the ecosystem. Next slide, please. What we wanted to identify is that we have a few different general interventions and a possible new intervention type. So specifically, in our intervention types, we've identified a specific type of activity that is not education, because it's really focused on behavior change, and in a way that education is not always focused on, and it's a critical element that we know now to be in the ecosystem, which is the intervention of coaching, right? So coaching as differentiated from education, because the literature on each of them is quite different. We have reimbursable CPT for coaching as distinct, and yet we do not have coaching as being an applicable intervention type. So we're very grateful for our colleagues in the N4A, AAA community helping us with some of the lit there. And then we also have literature from across the healthcare coaching, the health coaching ecosystem, to really test this other intervention type that then would be added to our others. So again, coaching as a specific intervention type to wrap around programs, to wrap around problems or asset statements or programs as appropriate. And we think this came up really when we think about addressing some of the readiness, which is not really counseling, or really some of the skills development that are fundamental for employment and education. Again, you'll see this into our different terminology structure on the masters as we go forward. Does coaching imply ongoing regular provision of services? Coaching is usually very goal-oriented, so it's really usually structured as more episodic. You coach toward a goal, as opposed to, at least that's the way the literature is implemented right now. And you'll see each of the definitions of these things, again, blooming on the masters as we go forward, and we'll put one on the Confluence as well. And the literature, we have literature from across the AAA community, the area agencies on aging community. We also have literature from the healthcare coaching ecosystem to support the addition of this new type. We also want to state that there is, yes, exactly. And this is the thing, is we already do know that there is a specific reimbursement code for coaching as distinct. So in some sense, our intervention type is a little bit late to the game. I'm just echoing what Emily is saying here. Within the districts, coaching is a critical, persona type and activity across the ecosystem. Yes, exactly. One of the things we tried to do is, really try to represent activities that different people, different actors across the ecosystem can do, because coaching is sometimes a layperson's activity or sometimes a professional activity. It depends on implementation. Yeah, so Lucy, I actually accidentally answered your question. So coaching can be something which you can have certification for, or it can happen independently. It's just as education can happen with a certification or independently. Again, the definitions will be clear as we go forward. We also wanted to, I'm just going to quickly pivot here for the sake of time. And again, this is all in development. That's why those big italics, like, we recognize this gap. We are testing this gap. There's evidence for filling this gap. And then we'll see how it plays out as we go forward. We also wanted to just recognize there are some common interventions that that our amazing intervention council, all of this comes from our intervention council work. This amazing gathering of social workers, clinicians, care managers who are helping us on Fridays at lunch every other week. Yay, Ellen! So common interventions, we recognize the need to have a common intervention of assessment of communication barriers, even though we do recognize communication as its own potential domain that has been suggested by community members. So it's in the parking lot for assessment, but we did want to put that there. applied more broadly the term coordination. When we think about what we do within coordination, we didn't have a full application of that term. So again, our friends on the IC have helped us. We're testing coordination of resources to address social needs, which is a general parent term that could encompass some of our lower terms, but also would kind of be an easy button, because we do try to think about simple terms that can be kind of a quick reference of what's happening in ecosystems that don't have the time to refine more fully. And then we also, again, from our AAA community, again, thank you, Courtney Baldridge, have coordination of service provision. And again, that was echoed as being important across the continuity of care world. So again, definitions for all of these things to come, but these are really critical, thought by the IC terms to apply, again, generally, not specifically to any of our domains, but to test as being generally appropriate for most of them. We also identified a new program that really could be applicable, especially when we think back on homelessness, community paramedic program that was suggested again through the IC. When we think about specifically the COVID use case, I personally leverage community paramedics to address health concerns within my homeless patient panel quite often. So we do want to test, again, this community paramedic program as a new program that might be applicable across historical domains, not just current domains. Coordination is an activity. So if we think about our activity types, this is why there's intervention types. That's a coaching types that if we go back one slide or back 2 slides, I'm just going to quickly go back. This right here, this is the structure with formal definitions that we plug all of our programs and professions into. You can see coordination is defined there according to AHRQ. And then, yes, and Jim, Emily already answered your question. Thank you. And these are proposed interventions, right? So nothing is really formal until we test it, right? So we're, and I guess maybe I don't understand the question, Rebecca. So we are proposing a new intervention type of coaching. Is that what you were asking? Okay, great. Okay, wonderful. Okay. And we feel like, again, there's just justification for it from the lit and from practice and from the policy, et cetera. Okay, now I think we can go back, and I'm sorry to take us back. I think it was just helpful for Lucy's question. All right, next slide, please. This is just our goal development framework. You heard me talk about the common intervention types. So again, you can see how our goal statement, stably housed, could drop in as that goal statement, and the problem homelessness would be the problem statement. So that's how those general terms, general intervention types are built out. And again, this slide deck, this recording is going to be available on the Confluence. So for reference, and we always try to be available for questions if there are them. Next slide, please. And Emily, you are indeed all over it, so thank you. Social connection, our SMEs, amazing crew. We're actually adding we're adding our stress SME, Dr. Eric Prather, to our social connection huddle next week in order to address a shared concern. So we collaborate across our different SME groups as necessary. Next slide, please. No significant updates here. We still have the goals as stated, and I do want to state that Tom had a lovely idea for a version of loneliness, of a loneliness goal that was not the antithesis that we brought to the SMEs, and that should come back shortly. It did seem to be applicable. And then Carrie, actually, I'm going to say from a culturally inclusive perspective, if it's a healing activity, it's a program, right? So we would just say traditional drumming program, right? We have specifically a fairly generic and not necessarily, we try to be inclusive, but you just recognize a pretty significant cultural gap. So I would submit that as a program, and then it can go through the hopper. So thank you, Carrie. Again, it's always important to see the areas that you need to make more robust. And we do want to say that's part of our lens when we think about our program, our intervention council work is really putting in different lenses to make sure that we're identifying different needs of different communities. So yes, Carrie, I think it is. um, does that make sense as an answer, Carrie? I hope so.
Yeah, it does, Sarah. I was just wondering because they're kind of hesitating about calling it a program. So
Yeah, so program is just our way of making things uniform, but if it doesn't, I mean, that's really because if you ever going to be intentionally connecting someone to something, right? We drop in the program type, but sometimes the word program doesn't seem to make sense and we just leave it off. It's almost like it's hidden there. But we can test it. We just need to pull it forward and then seek advice about how it would be operationalized.
thanks for that clarification.
Yeah.
No, drumming and art and
Yes.
theater and improvisation, all of that. Those are
Yes,
all seem obvious to me to be programs.
exactly. Especially within these social, like these intersocial domains, where like social isolation.
Yes.
Absolutely,
Yes.
no question. Yeah. And Jim, I don't know if I fully understand, but I think it's really how we try to build terms that are able to be utilized in different ways. And so if you look at the terminology options in some of our completed data sets, I think you'd see that it could be utilized either as a intervention specifically or a preventative method, depending on how it's put into use. Um, I don't, as a clinician, I don't see the terms being limited either to preventative practice or intervening on a problem. Because you could proactively do this, connect somebody in the absence of a problem. I think about, some of the emerging work regarding preventing perinatal depression, right? There are like scientifically proven programs that made it all the way up into UTSF, PSF, like category B, because they are depression preventive, right?
Yes.
So, yeah.
I was thinking, well, along like before the traditional drumming was mentioned, it was like, does a point of concern have to be also annotated with it? But I think what I'm hearing from you is not really, does not have to. It could be preventing a number of things.
And you could say at risk for too, right? So,
Yes.
yeah, yeah. And I think in many of our instances, there's either a strata of severity, like food insecurity, which extends, by definition, is everything from worry about to not having, or housing insecurity, which covers housing instability, which includes worry about not having, to homelessness, right? And then certainly within, yeah, so I feel like either there's many different ways it can be operationalized, but I think if you put the interventions into use, they could be used in either setting.
Cool. Thanks.
Yeah. Okay. Next slide, please. And we just wanted to state that we're still working on, nailing down some of our intervention types for social connection, and they should come to you very, very shortly. It's a little bit of a work in progress, but we're on it because we do have to kind of just parse the general national brainstorming into social connection intervention types, and so it's a sorting job we're doing right now. Next slide, please.
Sarah,
Yeah.
would you make sure, please, in discussing social isolation, the whole issue of being connected on the computer but not being connected to people?
Yeah, so that's exactly, Lucy, like
Thank
part
you.
of what we are doing with our sorting our intervention types,
Okay.
right? Like really trying to discern virtual versus like in-person connection, and the different kinds of that is 100%, not even 100. It's like I have that present of mind
Okay.
at all times. I promise
Thank
you.
you. Okay.
Yeah. All right. Next slide, please. Our amazing group of SMEs keeps on expanding, right? We were honored to add Dr. David Burns, who's a specialist in elder abuse goals and really through community participatory research. So he does qualitative research. He's based in Toronto. So we're just very, very grateful for this crew. Next slide, please. And then we are connecting with our social workers. They are connecting us with social workers and care managers and their teams to, again, bring us back. So you can see both the social connection group and the elder abuse group. The experts we've gathered are amazing regarding measurement and definition, because that's their area of work. But they've identified people within their teams who they're connecting us to for the interventions elements. So this is kind of a two-part step, and so a two-part process. So that's what we're doing right now. Next slide, please. And again, this hasn't changed very much. So one of the things I just want to state, and it's not really represented on this, is part of what we're also working on within the goals development work within elder abuse is really kind of specific addressing risk, right? So last time we presented on reaching plateau goals, which are this kind of adequate safety from to that final goal, which is the resolution. And Lucy, you're going to love this. So like one of the things that we are realizing is that there's specific risks you can address within that kind of plateau statement, which might be simply increasing social connection, right? So if someone is not necessarily able to leave like a situation of elder abuse, but they, but we can identify the risk of being socially isolated. We can connect them to, we can address the risk of social isolation within the domain of elder abuse. So a lot of the terms, these positive terms that we said all along, those goal statements can be plugged and played across many of our different domains as needed. And you can see the same thing from a neighborhood safety element, like if we were talking about adequate locks, or adequate safety protections of the home. You can imagine that being applicable here within elder abuse, and then again, applicable later when we address neighborhood safety. So the specific risk-based goal statements, again, working with Dr. Burns, should come up very shortly in front of the community so you all can review them. We expect them at least by next meeting and hopefully available on the Confluence prior. But so now we're having our plateau goals, our final goals, and again, those risk statements, which I'm going to clearly say so far really seem to be common goal statements that could be common across multiple domains because humans are complex, right? So, and that was actually a kind of reassuring, a really reassuring finding within our goal development terminology. Is the intent is to build things that are tools, right? Terminology tools that can be implemented across the ecosystem for different purposes. Next slide, please. Next slide. Is there consideration of isolation or abuse of caregivers of individuals suffering dementia? So our current use case is on not abuse of caregivers, but on abuse of, well, except for the fact that if the caregiver is an elder, it would apply. But again, caregiver role strain, like all of that is a whole other element that we can imagine discovering in future work, 100%. So a lot of the times these things come up, but they don't necessarily fit into the definition of the domain at hand. But we can imagine putting them in our parking lot, just like communication is in our parking lot, and trying to address it in future work. Next slide, please. Just wanted to add some of the programs again. So we talked earlier about the strategy, which are these intervention structure that we wrap around these programs. So it's education about, referral to, evaluation of eligibility for, right? So these are some of the core programs that are coming out of our education work. So Adult Learning Center, basic skills training, charitable organizations is kind of across all of them. Digital literacy, which again I want to mention, we've also talked about digital literacy and data justice being its own domain, but we're specifically referring to digital literacy. So Lucy, community college, our domain is less than a high school education, so we're specifically focused on interventions to get a person to the completion of the GED or high school. This is why we did not have like tuition reimbursement as part of this intervention at this time. Under education is a whole other domain, but we really narrowed our scope just to the lit of just a lack of a high school education, given the literature, the extensive literature about the health risks of not having that degree, which are vast.
So should you label that education interventions for less than high school completion?
Yeah, we can absolutely do that. That's how it's defined on our, I think we'll do better at putting it on the slides.
Okay,
100%. Yeah,
great.
that seems really great. Yeah. Yeah, so Mary, Sarah, so I just want to state that's actually how we imagine those goal statements as strength statements too. So if you can imagine, so these are our interventions, adult learn, and I'm going to hold space for your question, Mary, so I can answer it in a couple seconds, right? Because I think you'll see, I think you'll feel and see the answer in a couple seconds. I promise to go back to it. We did want to state ESL. This is partly how the universal assessment of communication barriers came about, though, is, it's obviously this came out as a need to understand, native tongue in order to refer somebody to ESL. But we really can't do anything until we assess communication barriers, including need for ASL, including need for, storyboards, including need for like absolutely anything. So that's why we created a universal intervention type. Then of course we have general educational degree and high school completion programs, which are both separate within adult learning centers, which are a federally aligned program, hence being named that way. Next slide, please. Goals. We have specific goals of high school education and general educational degree, but we're testing also these completion of blank program goals, really, because that's like a minor goal to get you to the greater goal. So that might be a different domain, Lucy, than what we're addressing right now. Again, we have to kind of go back to the literature really grounds us in not having that high school or GED degree because you can't get to the next step, right? We do want to, this is Mary Sarah, this isn't the best example, but let's just say that I had somebody whose primary problem was unemployment. I could say a strength is that they have a high school education, right? So almost all of our goal statements for specific domains can be used as asset statements with other domains, right? So if I have somebody who is food insecure, but they have a working car, right? So again, all of those goal statements can be utilized in asset statements or protected factor statements when doing, like eco map assessments or some kind of like proactive asset-based care planning. Does that make sense? Like that's the hope, at least. Okay. And again, that's kind of what we do within, when I'm working with patients who have maybe an economic social risk, I really try to figure out what they've got, what they don't have, has a strong, is socially connected, but is transportation insecure, right? So these are things that we do in a day-to-day practice on a, like every day in rural Vermont. Next slide, please. Again, employment, you can see this is all in progress and there's new, again, basic skills, workforce development, unemployment insurance, voc rehab, legal aid, fair employment, again, career fairs. And then we have some names in progress here. Again, this is in the hopper. They're not really named correctly, but we do want to identify that sometimes having barriers to care have to be addressed before you can actually seek employment, like the care of your dependent adult, family member, care of your parent, care of your children. And then there are some elements that come across from our financial insecurity domain we covered earlier. For all of these, we're applying those special population lenses. Like, what does it mean when we look from a person with a history of incarceration? What does it mean when we look at a person who is a migrant worker? What does it mean when we look up like specific populations such as Indigenous or Native American communities? Like we were going to put those special population considerations in there. Somebody connected, who has who's differently abled and needs to be connected through a DA agency. So all of those different special population considerations are going to be applied to these basic programs as we go forward. Okay. Next slide, please. Goal so far is employed, and Lucy, we did get I didn't do a very good job answering your question in the last meeting, but really we base our definition on the Census and Bureau of Labor Statistics, which includes part-time and gig employment in its definition. So, because for instance, with our same terms from the current population survey with food insecurity, et cetera. So currently the definition includes anything, as long as you're working X number of hours. It even includes working in your family's restaurant for a period of time. So that's all in, that the base of that definition is through the hyperlink from the Bureau of Labor Statistics. And you can also see has unemployment benefits and then completion again of those basic programs. Whew. Next slide. I'm really trying to get to Bob and Mark. Okay, those are just the word clouds for you, Lucy. They haven't changed. Next slide. All right, these are the veteran programs to come. New place setting, right, is the Veteran Service Office, absolutely critical. And you can see all of these specific veterans programs that are in the hopper, right? And they're going to be blooming on that master as we go forward. Again, some of them are specific to address concerns from other domains, such as homeless veterans community employment service or housing service, but these are all veteran specific programs. Next slide, please. And then this is just, we showed you this time, this is how we do the special population considerations. Next slide. Whew, we did it. Wow, that was a jam-packed. I hope it was intelligible. What I really hope is clear is the labor of it all, right? So we always are open to ideas, but there's a lot of kind of like, I call this process kind of like rock tumbling for those of us who were born in the 70s, right? We take these concepts and we put them in the rock tumbler and they kind of get refined over time. You all are really critical members for that rock tumbling. So please send us anything, any ideas, any insights. Really, gravityproject@emiadvisors.net is the best because then it doesn't get lost. It gets formally logged and we can formally address it. Whew. On to Mark, I believe. Next slide, please. Policy.
Thank you, Sarah. That's a lot. Next slide, please. So as you all have heard from me before, the Office of the National Coordinator did include 4 of the Gravity Project's data elements in USCDI version 2, and a huge shout out once again to the entire Gravity community for making such a huge contribution to the national health ecosystem. Considerable work remains now to implement, pilot, test, and iterate all of that we've accomplished with USCDI v2. So, for example, there's the ongoing development and publication of value sets that Sarah's just been describing, including fleshing out some of the ones that have been on the roadmap with the goals and interventions is a good example. On the technology side, real-world testing and implementing the clinical care IG beyond what we've already done with the Fire Connect-a-thon, so sort of making it real, testing it, iterating it. And then the pilots and the smartphone apps that you'll hear a little bit more about from Bob and have heard. We need to work on integrating that into the community and patient setting. So yes, a lot accomplished, but then there's a lot left to go because we have this philosophy of iterating, of taking what we've got, learning from the community, learning from what's happened, making it better. Next slide, please.
Mark?
Yes, Lucy?
Yeah, I'm wondering whether ONC funds that second bullet in the previous slide.
The thank you?
Does ONC fund the real world testing implementation and
Okay.
iteration?
It does require some real world testing that might actually, this may be not quite what you're asking about, but so let me take your question. I'm not aware of particular funding for that. Evelyn may have have her ears to the ground some opportunities, but I haven't heard anything yet. There is a phrase, real world testing, that is out there, a lot of discussion. In fact, there was a webinar this morning. ONC's regulations require EHR developers to do real world testing with their modules in the settings where they plan to use the HIT modules. And those plans have to be submitted in December of for the first time in December of this year, 2021. Then data is collected over 2022. And then that data, the results are reported to ONC at the beginning of 2023. That I do not believe is funded for the EHR developers. ONC, of course, has to fund its own work to monitor and learn from those results.
And Mark, I just put in the chat, yeah, just confirming that ONC's LEAP program, that is what it's focused on. It has a series of LEAP awardees right now, and the most recent one for the LEAP on SDOH was awarded to the University of Texas in Austin, and they have committed to test the gravity standard. So we are actually meeting with them, where the gravity project team will be supporting them in testing within their specific environment. And I think under the announcements, eHealth Collaborative also just announced 100K funding available to implement fire specifications. Does that help, Lucy?
Yes, definitely. There's no room in our meetings, but I'm going to ask if periodically this community could be informed verbally by our esteemed leadership about this real world testing. Where is it going on? Who is doing it? How is it going? Because all of us want to be able to say, we've had incredible philosophical and linguistic discussions, and we've come up with all sorts of terminology. And let me assure you this is being tested, or let me assure you this is being used, which we can't really say right now.
That is our intent. We have proposed a pilots work stream, so that's in our timeline. We said we would be launching it in the fall. So I'm in the process of securing funding to establish this work group where we would bring all the implementers. Again, this is just very much focused on the gravity standards. But we will have, that's the goal of this work group. So you are all aware and you are welcome to join it. It will be open. It will just be another, just like, you know, Sarah will have the public collaborative, Bob leading the firework, and then we will have another pilots work stream, and we'll bring this back to educate you. They just haven't started. So just acknowledging no one is implementing this right now, or they're figuring out, they're doing their pilot plans, and then we will have a work group where they will all come together. So please stay tuned. That's the intent.
This is wonderful, way beyond the scope that we envisioned in year one. So congratulations.
Yes, pilots. We just need to have the standards developed to issue the pilots. But thank you.
We're sort of like an onion. We're acquiring layers.
Yeah, terrific.
So to the next slide, please. So this illustrates where we are right now with version 2, what we submitted to the Office of the National Coordinator. And because of the structure, well, this is sort of what we submitted to the National Coordinator, the PMO has considered whether or not to make a submission for USCDI version 3, which would be due September 30th. And because of all that we've got on our plate right now, and what I'm about ready to lay out on this slide, we've decided not to make a submission of new data elements on September 30th, but instead to continue the work of making it real for version 2 and some of the things that we can do in the next 12 months without having to submit to USCDI. So next, please. So that includes, for example, the domains that are on the roadmap that you've been seeing from time to time from Sarah. Those continue. The value sets that we develop for those domains with the subject matter experts and then putting it to the consensus vote with this community collaborative, that all can go forward. It doesn't have to be submitted through USCDI version 3 because of the way ONC structured our submission. Next. Likewise, all of the work on the SDOH clinical care implementation guide, use cases that may be added to that implementation guide, an additional possible implementation guide on population health and research, those can go forward in the next 12 months without having to be included in a USCDI submission for version 3. Next. So what would not
Mark,
happen is we would.
when you say
Yep.
fire implementation guides, so this is HL7 constructing the groups or the bodies, I'm not sure what they're called, to do all this. This isn't, is that right?
These are the products. These are not the names of the groups that are doing it. So there will, but we will be coordinating with relevant groups at HL7 that may have some responsibility for some pieces of it. But we will be doing the design and carrying much of the water ourselves.
The Gravity Project.
As we have, yes, the Gravity Project.
Oh,
as we have
okay.
Today.
Thank you.
Now, these are not the names of the work groups at HL7. It's the name of the use case or the implementation guide.
So it says the heading is fire. That's why I raised this and
yes.
And okay.
So there were two data elements that ONC did not accept for version 2. We can continue to work on that. We over the next 12 months, but we just will not be making a submission on September 30th because we can't be sure that we would be finished in time for go live in July 1st, 2022. Next. And likewise, we had been giving some thought to these 3 new data elements. We can continue to think about and plan for those. But as you can see, we really have so much on our plate for the next 12 months. And our deliberations led us to the conclusion that better to get what we've accomplished so far done, get it done right, the real world testing and implementation, getting it in the pilots and the smartphone apps out into the communities and to patients, and that was probably plenty for us to handle over the next 12 months. So that concludes my update. Are there any questions? I think it's on to Bob then, if he's on the phone.
Hi, everyone. Bob said he had to jump off. It's Evelyn. And if we could move the update for next week, I think we can quickly go through the slides, just acknowledge that Bob was busy this week with the tech team at the Connect-a-thon. So if we move, next slide. Okay, next slide. I think he had a summary. So we wanted to spend some time here because, Bob and I had this chat this morning. We had a really good Connect-a-thon. We have reference implementations. We had over 40 participants, but no one came with code. So part of this is really important that as we move forward, I know we talk about pilots, we have a lot of things going on, but we really need to test these standards. So we look at our community at large to come to the table. We have many that do come, but just observe. And so for us is like, and I'm here, and I know Dan Vreeman is also be supporting us, is that we need to know what does it take to help you all come and test with us. We're planning another Connect-a-thon in November. And for that one, we will actually make a requirement that you come with code. So we'll follow the IHE model. IHE has Connect-a-thons where they invite people, but the requirement is you have to come and test something. So again, we welcome your feedback. We know these are new standards. The IG was just published, but we have reference implementations available. And we really hope that as we introduce the new one, that you can join us. Any questions? If you can go back to the slide so you could see how many people participated. And we want to know how we can work with all of you that are interested in this, that are developing code. How can we get you to the table to test? Okay, well, thank you. I know there was some questions I see here. Around fire IGs and the use cases. So we will develop some of these use cases noted here, and I could now say it, and I will announce it soon. Some of the use cases, even though if they're SDOH related, they may not be facilitated directly through the Gravity project, meaning we won't have a separate use case work group. They may be facilitated by other agencies. So for example, the CDC will be standing up an SDOH public health use case work group. They have their own communities of practice, but they will come and present this to you and invite you all. So just knowing that there's starting to be that there's other work. HL7 just announced the new human and social care, human and social care, social services work group, where they'll be developing use cases within that work group within HL7. So part of us within Gravity is trying to communicate this all to you and connect the dots for you all. But we're very excited to ensure that it connects with the outputs of this work. Okay, that's all. If there aren't any questions, I think we'll open up our hand back to you, Sarah.
Sarah hogged the whole meeting, so then Bob had to fall off. I'm very sorry. There was so much. I'm very grateful. Oh, yeah. So Gail, every single meeting is recorded and posted on the Confluence for reference, and this goes back to our origin. So if you ever want to spend a few 20 something hours researching all of the Gravity origin stories, they're all available on the Confluence. I do want to thank Mark for his really significant work in his update on USCDI v2 and v3. Next steps are really just to continue to support the work of the terminology build and the tech. So if you ever need to catch up on the Gravity Project materials, the Confluence is there. I really want to just deeply thank the folks who've been submitting elements on via email. We get and log and review every single element that comes by email and route them appropriately to the different subject matter experts. If you have any submissions for either programs or professions across the different domains we're covering, please submit them. And then really just review the different data elements as they start to bloom on the Confluence. Really ready yourselves for the end-to-end review, which comes shortly. Remember, the end-to-end review is a way to collectively refine the set together before it goes into vote. And Jonathan, of course, you can ask a question.
I don't want to interrupt you mid-sentence. I'm happy to wait.
Oh, this is very much my way. It's very much a collaborative conversation. So what is the question? And we're happy to try to answer.
Okay, hello. So Jonathan Fite, Beyond Lucid here. So I guess my question is, to the degree that you're talking about folks submitting for the data elements that they're working on. In my particular case, we announced earlier this week a deployment related to EMS and fire, spelled F-I-R-E, not F-H-I-R, for anyone who's keeping score, related to social determinants of health. It's very important to me that we are not building in a direction that will ultimately be different from the collective here, especially since there's a lot of overlap sort of naturally by the subject matter. You did mention community paramedicine, of course, Sarah. That's sort of the origin story for this stuff. I guess my question is there a forum by which to meet with any of you to sort of review what we're doing? I think there are going to be gaps in what we've already done. There also may be things that we are doing that had not occurred to the group. And obviously this is not the appropriate forum per se to go through them in specific, but I think if we could do a deep dive, that would probably be extraordinary.
Yeah, So I think there are two forums or a collective forum depending on what you're asking. So if it's about terminology specifically, which I don't imagine it is, it would be you and I could just huddle, or myself
Sure.
and any member of the team. All the terminology products, both as publicly, and this is probably helpful for anybody on the call. So what I'm saying right now, so that you can best envision and see the terminology and development through two different phases. So one is the terminology we propose. So any domain we've covered in the past, and this includes food insecurity, housing instability, homelessness, transportation insecurity, oh my Lord, stress, interpersonal violence. It goes on and on and on. Any of the master lists of what we've proposed are available on the Confluence within the domain of reference within the terminology section. And then there was that slide that I presented earlier, which is what is really the final state. So there's what we suggest and what we build together, and then there's what gets built. Because in between suggesting things is the process of going back and forth with the terminology stewards and moving things into code. Right, so that table, which is really SDOH data elements and status, that's where you can find all the terminology that's already been built. If it's about tech and alignment with the IG, you can also find that on the Confluence, or you can have a meeting with us. So I guess and we'll follow up on the email, but if it's aligning with the standard, that would be Dan and Bob and that work. And then if it's aligning with terminology, that's me. And if it's aligning with all of it, it's all of us.
Yeah, and I think it is, at least in my case, I want to make sure I throw this out again because you mentioned community paramedicine. So the and some, I think it was Evelyn also mentioned IHE, and I'm working with some folks from IHE in parallel on literally a white paper trying to explain to folks who traffic in HL7 how it is that EMS operates. They use a different data set, so you've got hl7.org on all of these things just on screen right now. We work in Nemesis because if anyone who's seen Contact, the movie, the first rule of government contracting: why build one when you can two at twice the price? Nemesis is not HL7. They are not naturally interoperable. There are ways of doing it, but we're building in a different world that crosses in here. And so
that's where I think you need probably both of us. So I think
yes,
if you send us an email, I 100% we actually leverage some of our existing meetings for stakeholder meetings such as this, and I think that we just need to kind of get everyone together and see what we need to do.
Happy to do it. I said, I just want to make sure that this is something, as you guys are saying all the right amazing things, and the fact that there is a world with the folks who have sirens on their trucks, and they're building in a different direction, and they're kind of doing it in parallel, and we really need to sort of bring everybody to the middle. So I often end up being the guy who has sort of tugs at the neck. So this seems like, especially you talk about things like Connectathon, I'm sitting here sort of salivating over the idea of doing it, but knowing that our data set is completely different. It seems worth.
Yes, and maybe we should get our policy folk and Mark in there too, because all of our work is bound to align to federal HIT policy. So that's our, an HIT terminology and standards, and so that's our domain. So we'll based on your email, we will circle back around.
Copy that. Thank you, Sarah. I appreciate it. Yeah, good.
Sarah, this is Dan. I might just chime in.
Dan?
There's a starting point in that I think it's back to version 3, so we have some catching up to do, but I was involved way back with representing all the Nemesis data elements in Loink. So there's a beginning point, and we probably need to do some resyncing, but we're not in totally foreign territory.
Thank you, Dan.
And depending on how far back that goes, Loink has been a big grinding point for interoperability in EMS. So Dan and I could probably have a really animated conversation about that. It goes back years. So yeah, Sarah, I'll email you guys. And Dan, if you could put your email in here, I'll be glad to include you on it if that's appropriate.
Oh, Dan is you'll get Dan if you write us. I promise you.
Yeah. Thanks, guys. I'm sorry to talk so long. I just you're getting into the technical weeds. This is kind of where I raise my ugly head. Thank you, guys.
Yes. All right. Okay. I know. So we are the Borg. We assimilate, right? This is the Lucy. We also assimilate ourselves too, though. We always recognize when standards expertise is outside of our world. So, and just try to, because the truth is we represent all of our different stakeholders. So, and that is the collective, right? So even though we speak from an HIT perspective, we represent the wisdom of the 6 stakeholders that are our anchor. All right, I think we're good. I don't think we have any other questions. I saw Karen connect to Evelyn. Really want to wish you a lovely
Sarah,
yeah.
I'm
Hi.
sorry. Could you go back to slide number 63? I would like to grab it, please.
Yeah, sure. That sounds great. I mean, I have no power in that. Whoever's smart and thank you. Is this the one you wanted?
Yes, just a
Okay.
second. Got it. Thank you.
Lucy, we're always happy to send you a copy of the slide too. You're Lucy.
I just
Your family.
saved you 2 minutes of labor. Thanks.
Okay. Everyone, thank you so much. Oh yeah, so there's a Julia, I'm so sorry. So I'm going to answer this question publicly because if you ask it privately, someone else might have the question too. So the question is whether we'll be using both LOINC, SNOMED, and ICD-10 CM. The answer is yes, all of those and more. So the Gravity Project, if you look at really there's a really good reference in that table again of conversations that are things in build. I mean, things that have been built. We encode across, we work with terminology standards orgs across Registry and LOINC, SNOMED CT and SNOMED International, ICD-10 Coordination and Maintenance Committee, both for ICD-10 CM, and we are also appealing and commenting on ICD-10 11 through the World Health Organization. And then we also work as necessary and facilitate code in our stakeholders to build codes within HCPCS when it's appropriate. The only one we've done so far is really medically tailored meals. And then, of course, we work in consort. If you look at our tables, you can see references to HCPCS, existing terminology, and CPT. And of course, if we ever get forward our quality work stream, you can imagine CPT2 as well. So if it's in HIT as terminology, it's in our world. And we work actively to encode across all of those orgs. Which is why we are very busy. All right. Thank you so much, everybody. Again, the STOH Fire ID meetings are Wednesdays 3 to 4 Eastern Standard Time. All that information is on the Confluence. I am so grateful to be part of this work with all of you, and we will see you in 2 weeks. And you can only imagine the work that will happen in between now and then. Take care, friends.
Thanks, everybody. Bye.
Thank you.
Thank you.